Hi, everyone. Thank you so much for allowing us to present our work today. A standard disclaimer, and we have no disclosures. Along with control of hemorrhage, the resuscitation of traumatically injured patients is a critical component of their treatment and directly impacts their survival. Recent military experiences in Iraq and Afghanistan have demonstrated that whole blood can be extremely beneficial when given to patients who present in hemorrhagic shock. However, when transitioning this knowledge product from the military to the civilian settings, there are very real and valid concerns about the risks of transfusion reactions when giving an untyped unit of product to a trauma patient in the trauma bay. One way to mitigate this risk is to use low-titer O whole blood, which is type O blood with low titers of anti-A and anti-B antibodies, which thus far in the literature has been shown to not be associated with an increased risk of transfusion-related reactions. Brooke Army Medical Center is a level 1 trauma center in San Antonio, Texas. We accept trauma patients from both the San Antonio area and then also more broadly the South Texas region as a whole. We began stocking low-titer O whole blood in our hospital in January of 2018. And so really the purpose of this study was to evaluate our early experience with using this treatment modality and look at any safety and outcome data that we had available to us for patients who had received whole blood. So to perform the study, we retrospectively reviewed our database. We included patients who presented in hemorrhagic shock between the dates listed there, and hemorrhagic shock we defined as at least one of those 3 criteria. An additional inclusion criteria was that patients had to receive at least 1 unit of blood product, whether that be whole blood or component therapy, so PRBCs or FFP, within the first 24 hours of arrival in the hospital. We excluded patients who received pre-hospital whole blood. A number of our EMS units now carry whole blood with them in the field and can give it to certain trauma patients prior to arrival in the trauma bay. We grouped our patients up based on what type of therapy they received. Group 1 received whole blood only, Group 2 received component therapy only, and then Group 3 received both whole blood and component therapy within the first 24 hours. We collected demographic, injury severity, resuscitation, and outcome-based variables. We compared these groups and then performed a regression analysis to try and identify any independent predictors of mortality. Variables that were included in that regression are listed below and essentially include vital signs on arrival and then markers of injury severity, as well as the type of resuscitation that the patient received. So this is a table looking at our groups, the demographic variables of our groups, and you can see that really the vast majority of the patients who received whole blood, so patients in Group 1 and Group 3, the vast majority of those patients were male. Very few females ended up receiving whole blood. This is a table looking at ER assessments of these patients as they hit the door, so initial vital signs and very basic laboratory measures. You can see here that while there are no differences, statistically significant differences between groups, Group 3 appears to be just a little bit sicker than the other 2 groups. They have a slightly lower systolic, slightly lower GCS score, slightly higher lactate. And this is confirmed in this next table, which looks at scoring of injuries. The Group 3 patients, so patients who received both whole blood and component therapy, were substantially sicker. They had higher ISS scores and lower TRIS scores on arrival. This next table looks at the number of units received by these patients for resuscitation in the first 24 hours of hospital stay. You can see that the Group 3, the whole blood and component therapy group, the group that is more critically ill, received not only the highest number of units of whole blood when compared to Group 1, but also the highest number of units of PRBCs and FFP when compared to Group 2. So again, these patients are more profoundly sick when they arrive, and they're getting a much more robust resuscitation. This table looks at outcomes. At the top, days on the vent, ICU length of stay, and hospital length of stay are shown, and you can see that there are no significant differences between groups. At the bottom are complications that we felt would be indicative of a severe transfusion reaction, so PE, DVT, unplanned ICU transfer, unplanned intubation. Certainly, while these are hopefully sensitive for a severe transfusion reaction, they're not at all specific for that. But we felt that including these complications would help us capture those extremely severe and very clinically relevant transfusion-related reactions. And you can see that there are actually no differences here between groups. Patients who received whole blood, Group 1 and Group 3, did not have a higher incidence of transfusion-related reactions when comparing our groups. And then finally in the middle are mortality endpoints, 24-hour, 30-day, and overall mortality. Mortality was higher in the whole blood and component therapy groups at 30 days, and then certainly trended that way at 24 hours, and overall that did not meet significance. On the left is a Kaplan-Meier curve that looks at survival over time, and you can see that really the differences between these groups evolve over the first 24 hours of hospital stay. And while there are certainly changes to survival after that time, those really profound differences are established right away. This reflects again both the initial resuscitated period and also the injury severity of the patient. On the right side of the screen are the results of our regression modeling. You can see that the only independent predictor of mortality at any of the endpoints measured, overall 24-hour, 30-day, was TRIS score. Our study has a number of important limitations. First, it's a retrospective study with relatively low power, and so that all of our results need to be viewed in that context. But secondly, and also very importantly, we're looking at a very heterogeneous population, and our groups have poorly matched injury severities. And so our results, and particularly our survival results, should be interpreted in that context. Even with these limitations, though, we can conclude that first, most of our severely injured patients received not just whole blood or not just component therapy, but really a combination of both. And then secondly, that low-titer whole blood does appear to be safe. Cumulatively, this study suggests that patients who arrive in extremis in need of a substantial resuscitation are really just receiving whatever product we have available, whether that be whole blood in the ER, whole blood from the blood bank, or component therapy as needed while the whole blood units are being prepared. And I think that this really highlighted the importance of developing good processes around the administration of these products in the trauma bay, and then continuing that up to the ICU or to the OR, wherever this patient is headed. And so this is something that we are focusing on at our institution to really build the ability to give a robust whole blood resuscitation to patients who very much need it, but then also to try and protocolize administration of whole blood so that once patients have definitive control of bleeding, or once patients are in the ICU and resuscitated, knowing when to either transition from whole blood to component therapy, or just to stop resuscitation because that patient is adequately resuscitated. In the future, we're again looking at protocolizing our whole blood use at BMC, but then we're also hoping to look at the pre-hospital EMS units who are giving whole blood, and trying to identify patients who they can administer this therapy to, where it will be the most beneficial. My references, and then thank you again for allowing me to present our work today.